For this lecture, we will cover Chapter 7, Basic Serological Laboratory Techniques and Clinical Applications. So first, we will just start off with some basic terminology. So I do encourage you to run through these next couple of slides and familiarize yourself with this terminology. If you have any questions about anything, or if you are uncertain about any of these terms, be sure to reach out to your instructor. Or you can do a more in-depth research on the particular topic. Now let's move on to our lecture material. Serologic testing over the years has been a very important part of the diagnostic testing that is done in the clinical laboratory for viral and bacterial diseases. Immunological testing is done in many various areas of the lab to include areas like microbiology, immunology, hematology, immunohematology, which is blood bank, as well as many other areas. And it does we do actually use a variety of specimens when we're doing this testing as well. Rapid testing is typically used in the laboratory as well as home testing kits. And with the advancements of monoclonal antibody testing and technology, this has led to the development of very highly specific and sensitive immunoassays. Some of the common serological and immunological tests include pregnancy tests for the HCG hormone, and tests for infectious mononucleosis as well as syphilis. Now, as we previously discussed in intro, each laboratory is required to have procedure manuals with very detailed and specific procedures within them. Now, the laboratory can use package inserts as a reference, but they cannot use it as a standalone procedure. Procedures do have specific details which they must include that or must include certain things, and they must comply with the Clinical Laboratory Standard Institute format. So it's going to include things like test preparation, how the facility reports and handles certain things in that facility, anything that's interfering, how the test is reported, safety precautions. There's several different things that must be included. So when you're in the laboratory or in your clinical site, be sure that you're kind of taking a peek at these procedures just so you can kind of be familiar with them and the format and layout of them so that you know where to find information should you ever have a question. Now, one of the very important things that's actually included in a procedure is what specimen types are used for that particular procedure. So it will list in details the collection tube, the collection method, any kind of prep that's required. So you always want to be sure to refer to those specimen requirements just in case there's anything that needs to be done. So after blood has been obtained for any sort of serological type of procedure, it's usually going to be obtained in a plain tube without anticoagulant, although there are some procedures that do accept an anticoagulant as part of that specimen. But if the specimen is collected in a plain tube, it should be allowed to clot so that serum can be properly and promptly removed after that clot has formed. This kind of helps prevent any kind of further degradation from happening. Now, depending on the test procedure, it could require additional prep of that specimen. For example, it could require a frozen specimen, especially if it's samples that can't be tested right away or within a certain time frame. So make sure that you are familiar with that for the particular test that you're doing. And even if it is a send-out test, you may still have to do some of these preps. Now, you do have things that can interfere with your test, and this, of course, would be listed within your procedure. And things that could interfere with testing would be something like lipemia, hemolysis, bacterial contamination. If a sample is icteric or turbid, if there's any sort of chylomicrons or anything like that that's in that sample, it could interfere with the test just depending on the test, but what you would need to do is just be aware of what things interfere. So if you cannot accept that particular sample, then you would request a redraw. For example, some specimens or some tests may have interference from any sort of turbidity. So it's best that you have a patient that is fasting, because if you collect that sample shortly after a meal, then you will start to see those chylomicrons, which is those fat globulins that will appear in serum after a patient has eaten. And then that will cause the turbidity, in which might interfere with the test method. Also, contamination with alkali and acid must be avoided, because these substances can sometimes denature the proteins and things that are within that serum sample, which could ultimately alter your test results. Now, while serum is typically going to be the primary sample that's used, there are some tests that may require other samples, or that may test other samples for something. So examples of this would be urine, testing for a pregnancy, or any kind of bacterial contamination, things like that, or any kind of breakdown byproducts. Things like spinal fluids could be used, or other body fluids, swabs, exudates, discharges. Some of your testing that's looking for premature rupture of the membranes, as far as, a pregnant patient's water breaking early. So that will be an example of a swab type test where you have some type of discharge of fluid that is submitted. Some procedures may require the use of inactivated serum. So inactivation is a process that will actually destroy the complement activity. So complement is known to interfere with the reactions of certain syphilis tests and complement components. So it can actually agglutinate the latex particles that are used within the testing, and actually cause false positive reactions due to the visualization of that agglutination. Complement may also cause lysis of indicator cells when you have hemagglutination type of assays. And so complement within body fluids can be inactivated by actually heating it up for 30 minutes at 56 degrees Celsius. When more than 4 hours has elapsed since inactivation, a specimen can be re-inactivated by heating it to 56 degrees Celsius for 10 minutes. It's often necessary to actually make a dilution of a specimen that we're going to analyze in order to make a weaker solution from a stronger solution in many of the laboratory procedures that are done for your serological type of testing. So as a lab tech, you're going to be expected to work with and know various dilutions and be able to figure out those dilution factors. This is why we spent so much time on this and focusing on this when we actually discussed it in intro and lab math. So we were kind of building you up to this point to be able to start recognizing when you make these dilutions of actually why they're relevant and how to actually do that math. So when you're diluting a specimen, you're actually just taking a small sample and then you're mixing it with a diluent to make a smaller concentration of the original patient sample analyte that's present in that sample. Now, sometimes you may have to do this just to kind of figure out, what ratio a patient's sample is actually demonstrating that particular concentration. And you could use this for monitoring things like if antibody titers are getting stronger or if they're getting weaker. Just whatever the particular procedure says as far as what you need to do, that's what you need to follow as far as if you do a dilution. Now, if you do a dilution, then you will need to know that dilution factor. Again, this is why we concentrated on determining these within lab math, because once you figure out what your dilution factor is, then of course you're going to have to multiply your final outcome or result with that dilution factor and able to get your final concentration. Now you can do single dilution, so this is just where you're going to take a portion of your sample and mix it with a portion of your diluent, and then you'll get a ratio. And of course you will need to know that dilution factor in order to determine what your actual final result is, what your final concentration is. So dilutions can be done single or they can be done in a series. Now with your series dilutions, you're basically going to start off with your concentration of your sample. So your first dilution may be made. So in this particular example, it looks like they're doing it by half. So you have 1 part of sample volume that's mixed with 1 part of diluent volume in tube 1. So we know that that is half of that. So if we move half of that over to the next solution tube that already has diluent and mix that, then it's going to half that solution even more. So then you just keep going. So basically what your serial dilutions are going to do is set you up for the ability to perform titers, antibody titers. So we're going to talk about that here next. When obtaining specimens from a patient for serological testing, it's very important that we actually consider what phase of the disease and the actual condition of the patient when we draw and collect that specimen. And so when antibody levels are tested for a specific infectious organism, we should actually draw blood during both the acute and convalescent phases. And so you can actually have a difference in the amount of antibody that's present, or what we are actually going to talk about and look at is an antibody titer. It can be noted with the 2 different samples that you're testing for that patient. So a rise in titer is central to the serological testing. And so you can actually see the difference in these levels in the acute phase versus the convalescent phase. So as we previously talked about, you have different antibodies that respond during different phases of an actual inflammatory type of process. You've got your IgM antibodies that respond first, and then you have your IgG. Depending on if the patient has had a previous exposure, is going to depend on how quickly those IgG are actually formed and actually respond. So it could be possible that you would actually need to do some antibody titers in order to determine if those levels are actually changing. Because if you draw a specimen at the acute phase, you may or may not have those antibodies present. Then as that convalescent phase sets in and those antibodies start to rise, then you're going to see a higher spike in them, which means that when you actually start doing that testing during that convalescent phase, you're going to get those strong positive reactions. So doing an antibody titer and diluting down the concentration of those antibodies that are present kind of helps us to put a numerical value or a semi-quantitative type of value on the patient as far as a level of where they're at, so that we can continue to monitor those levels. If those levels continue to rise and that reciprocal of that dilution factor continues to go up, then we know that either the patient is still in that active phase or that there's something still stimulating it. However, if we note that those levels are coming down, that can indicate that they're coming out of that phase, that treatment is working. Again, kind of the opposite of that, those levels are going to keep going up if treatment is not working. So doing that dilution, and when you do that serial dilution, if you test at those different concentrations, then the antibody titer itself is actually going to be the reciprocal of the highest dilution of that patient's serum in which the antibody is still detectable. So our last positive result in that titer. So if you have a patient that reacts at 1 to 2, but not at the next dilution of a 1 to 4, then they would be considered a 1 to 2. But if you were to test them a couple weeks later and they were at 1 to 4 instead of 1 to 2, then we know that there was a rise. And just a bit of a refresher. Point-of-care testing is defined as laboratory assays that are performed near the patient. The development of new point-of-care test assays has increased at a very rapid rate. Obviously, you know this because the having the availability of the COVID testing kits commercially now. Point-of-care testing can include home test kits and a handful of monitors. The major advantage is that you're able to actually rapidly obtain quality results if you actually perform this procedure properly. One of the drawbacks is cost, particularly if you have a large volume of testing that is done. So, for example, some of your laboratories may switch over to an automated test method if they're just unable to keep up. I know, like with some of the PCR testing, some of these labs that were doing the point of care testing were going through several kits a day. So, you know, some of these larger facilities, that's when they looked at actually bringing on some of the automated testing versus those point of care test kits. This just kind of helps speed up the process by, as well as lowering costs, because you're running a big batch at one point versus someone having to actually set over a point of care test kit and watch it and tend to it. Not to mention it's easier to kind of throw a bunch of samples on a machine and walk away and forget it versus actually sitting there doing the testing and setting the timer and reading the results and recording those results. So if you're getting a larger volume, actually switching over to an automated method may be more cost effective. Now, within the laboratory, CLIA has established that that tests do fit into 4 of the following categories, to include wave testing. These are your simple tests that are very simple to do with little chance of any sort of negative outcome if they're performed inaccurately. Examples of this is going to include your point of care test. Moderate complexity tests, these are more complex than wave tests, but they're usually automated. So this will be just your general everyday chemistry testing, enzyme immunoassays, your CBCs, just putting the things on the machine and letting the machine run. You also have high complexity testing. This is usually non-automated or complicated tests that actually require a considerable amount of judgment. These are going to be more your testing where you're going to have some complications if things aren't done properly. Examples of this will be like serum protein electrophoresis, doing blood types and cross matches. Some of your micro testing will fall into this category, like plate reading. And then you also have provider-performed microscopy, and this is when the physician or nurse practitioner, someone who's had proper training, will actually review slides that are collected at bedside. So this is going to be something like wet mounts or body fluids, things like that. Now, test complexity itself is based off of FDA standards, and it's determined by specific criteria that assesses knowledge, training, reagent, material preparation, operational techniques, QC and QA characteristics, maintenance, troubleshooting, and interpretation and judgment of the particular test. So anything that gets approved by the FDA, they assess these categories and then they determine or assess those various criteria and then determine which category to place those tests into. So again, wave testing are simple, easy to do type of testing. They don't really pose any risk or harm to a patient if it is performed improperly or interpreted improperly, and they have been cleared by FDA for home use in most cases. A Joint Commission, their standards, as far as what they say, that as far as what you should be required for your facility when using wave type testing. So you need to basically, you're going to have a procedure in place for each of these tests, and of course you've got to identify which test you will be using and performing. You have to report this for whatever accreditation agency that you use. Even though it is a waived test, you still have to let them know what test you do still use in your facility. And this just kind of helps with tracking. If there's ever any kind of recalls or issues, then they kind of know exactly who has what or who tests for what. If there's ever any kind of inspection, then they know when they come in that they should expect to see this batch of tests being run in your facility. If you're running something else or you're not running that, then there's going to be issues. You do have to have a way of confirming the test, especially if the procedure says that, you know, for you to confirm any sort of positive or negative reaction, then you do need to have something in place as a way to confirm results, whether you do it in-house or it's a send-out. You do have to list any sort of instrument maintenance that's required, as well as QC checks that are done. Now, I also want to make note that within QC checks, part of that QC/QA policy, you do have to have for wave testing as well, and it's going to include a way to assess staff competency. Typically, it's assessed at orientation and annually. Depending on your state, local regulations, some sites may do something like your original training plus something like 60 or 90 days or 6 months in, and then annually. So that can be site specific, but most places are for wave testing is at least initially typically 6 months in and then annually, but I don't know that all states require the 6 months in. Also, for QC, you must follow manufacturer's instructions, and typically it's going to include 2 levels of QC, usually a positive and a negative, or a high and a low. If it's available, there are some tests out there, very few, that there is not any QC material made for, but that's very rare. Most of the point of care test is done by a manual rapid type of method. Most tests that continue to be developed are basically going to be for use for like emergency departments, hospital settings, nursing homes, physician's office, bedside type of things, and sometimes even home use. We're going to talk about just a couple of these tests that are available for rapid testing. You may be familiar with some of these. I'm not expecting you to know a lot of detail about them. Just kind of be familiar a little bit with the principle of it. So malaria testing, of course, the gold standard is still to visualize that organism under the microscope. But there have been some rapid detection tests that have been developed over the years that will actually detect the presence of malaria within that specimen. And so what this particular test does is it actually looks for, within the patient sample, when the patient sample is actually applied to the kit and it's absorbed into an absorbent membrane, then what it's actually looking for to detect is particular antigens that are specific for the plasmodium. Now, it could just be some type of protein or something like that, but it's something that's in that actual antigen on the surface of that cell that it is actually looking for. Obviously, as with any test, you do have room for error. So these particular test methods do require that if the test is negative, then you must still make a slide and confirm it microscopically. My personal opinion, if I've already got to make a slide, if it's negative, I might as well just do that in the first place and look at it. So I don't know that this would be very cost effective, other than it would allow a rapid screen and less tech time actually looking at the microscope. But you know, particularly in our areas, although malaria is starting to be seen more in the U.S., but in our areas, you're most likely going to have more negative than positive. So again, I think I would rather just look at it under the microscope. There are some rapid HIV testing out there now. However, if there is a positive on these, they must be confirmed with some sort of 4th generation immunoassay testing, just because those rapid tests have a lower clinical sensitivity. Most of us are very familiar with pregnancy tests. This is actually going to be one of the first tests that you ever really encounter out that you may have encountered. Now most people are pretty familiar with these rapid tests because about everybody's had a COVID test, or at least familiar with the over-the-counter COVID testing. Now with pregnancy testing, the original test kits actually relied on an antigen antibody type of reaction. These methods are still available, but they have been replaced over the years with different methods. For example, there is one manufacturer out there that uses a pregnancy test kit in which it is solid phase, which is a sandwich format immunochromographic assay for the qualitative detection of HCG. And what will happen is when that sample is introduced to an absorbent pad, then it will migrate across and it will actually bind to some monoclonal anti-HCG dye conjugate, and then you'll get the presence of a visual line. All right, let's kind of go over a little bit about these rapid diagnostic tests. I think the example here that your textbook uses was for HIV, but they all kind of work very similar. They kind of have the similar approach. So we'll just kind of talk about it. Like I said, even though I think this is for HIV test, your pregnancy test, a lot of your rapid diagnostic tests actually are kind of the same way as far as their layout and how they work. This particular test here, this whole end down here is just going to be where we kind of see our results, whereas this end here to the right is where our reaction is going to take place, where we place our sample, any kind of buffer that's required. Not all of your tests require a buffer to actually go onto the test strip itself. Some of them take just sample. Some of them you may have a prep step that happens in a test tube outside of this, and then you will actually put that particular solution over into your sample well. So they're all a little different, so you will definitely want to be sure you read your procedure. So in the first step, actually let me point out here, they flipped this test strip. So up here, your sample goes towards the right. Here, this is our sample reaction type area that's going to take place, where this is going to be like this end down here is more of our detection area, where you're actually going to have those antigen antibody complexes take place. So our first step involves mixing the patient's blood with a lytic type of reagent in the test strip or the well. And what this will actually do is it'll rupture those red blood cells. So this particular test, if it's HIV, remember you've got those antigens that are present on the outside due to that HIV virus being present in those cells. So when you rupture it, you're actually going to break those antigens off, and then you're going to allow for that detection to actually take place. All right, so down here on the end where we are actually going to place our sample and all of this lysis and everything's going to take place, you got a lot of stuff going on here. You got dye labeled antibody that is going to be specific for the target antigen. And then you've also got any sort of lytic agent that might be in those wells. You got a lot of different little things that are going on down here at this bottom end where you're actually going to put your patient sample. Now a little further up where we actually see the test results where you have that antigen antibody binding taking place. In this area where you actually have the test band that's going to be present, in this area you're going to have specific target antigens that are bound to that little strip in this little area here. So they're actually in the strip even though you can't see them yet. They're there. And then you also have an antibody specific labeled antigen or antibody, just depending on what this control band line uses here. That will be here. Again, you can't see it. You're not going to see it until it's activated once these solutions and patient samples put in. Okay, so now what actually starts to take place? So we enter all of our stuff here at these little wells that were down here at the end. You got your buffer that's going in. You got your your patient's blood that we're looking to see if they've got any sort of whatever we're looking for. This particular case, they're seeing parasite, that HIV virus. And you're placing all this together. It's going to allow those antigens that are labeled within this particular the sample whale down here, where you've actually got all of this labeled antigens that are present in there that are going to attach to that, or excuse me, they are labeled antibodies that are going to attach to that antigen that we just broke off, or that we're breaking off in this process. So that's going to allow those to attach to this labeled antibody. And so you can see that it's actually labeled with something that we can visually see. It's got that little purplish dot there. And then what that's going to do is all of that's going to flow up this strip. If you've ever seen a pregnancy kit, or if you've done a COVID kit, you kind of see where that pinkness starts to flow up through that little strip. If that antigen is present, then you've actually got these bound antibodies here. So you can see this little flat blue area. That means it's actually bound to the strip. So this is what you actually have all in this little line here, is these bound little antibodies that are attached to that filter paper. So when you have that antibody that's labeled with that visual dye of some sort that comes across that has that antigen from that parasite attached, then you start getting this labeled complex that's going to happen here. And then you have the additional ones that will move on and actually hit that control band as well. So if that antigen is present, you're going to see the manifestation in that test line that's going to show up positive, because it captures them as they come across it, and then it stops them.